I think the long-term challenges are going to be one is management of toxicities with these agents. So in general, although these agents are much safer than many of the agents we use in treatment in AML and ALL, they do have some unique toxicities. So especially with midostaurin, we do see that there may be a skin rash, sometimes there's some increased nausea, taste changes. Most of these, once an individual is aware, are from the drug, can be treated with anti-nausea medication. Sometimes for the rash you give low-dose steroids, etc. With quizartinib and gilteritinib also there are some unique side effects. With quizartinib especially, we rarely can see increased QT interval, which is a cardiac issue. Now luckily there have been more than 1,000 patients treated on quizartinib, and the incidence of actual clinical cardiac damage is very low. In fact, just 1 out of 1,000 patients had it, and even that may have just been by chance because a number of these patients are elderly patients. But that being said, we do recommend monitoring for the QTc interval. This is included in all the phase 2, phase 3 studies of quizartinib, and especially one has to be careful when they add other medications that may concurrently increase the QT interval. So I usually recommend my fellows, my students, whoever is following these patients, to keep an eye on what other medicines are being added. For example, if you have somebody on quizartinib and then you start them on Zofran, and you start them on Levaquin, and you start them on posaconazole, then you may get into a situation, because you have now 4 drugs that can impact the QT, and you may get into a risky situation. So I think the physicians who use this need to review some of the major papers, some of the list of drugs to be used with caution, and a lot of this can be offset easily. You could use drugs such as Vantin instead of quinolone. You could use Cresemba instead of posaconazole, and if you use these simple alternatives, then you reduce the risk of QT prolongation and potential impact. With gilteritinib as well, there is a smaller but an incidence of QT prolongation, so the same rules apply, and there is a small incidence of GI toxicity, diarrhea, nausea, etc. And again, these can be managed well. So I think awareness of these drugs, concomitant medications that are safe to use, not safe to use, is going to be important. I think the second critical thing is going to be access to these drugs, because in the end of the day, most of these tyrosine kinase inhibitors are expensive, and we don't know if all hospitals are going to be able to stock them. And I know the big academic centers will, but in the community, I think there's a lot of effort made by the companies, by Astellas, by Daiichi, by Novartis, to try to develop good patient access programs. And I would say most of the community practices should reach out to their local patient advocate or local medical liaison and try to figure out what is going to be the way to get quick access to these FLT3 inhibitors, because when the patient hits the door, there should be some form of system in place. And I do know all of these companies that are making FLT3 inhibitors have some form of other of getting quick access. Some of them are giving free drugs, some of them have very quick patient advocate programs, etc. And then the third big debate that we're having right now is the use of maintenance, especially with midostaurin. So the phase 3 data showed that the midostaurin was most beneficial when it was used with induction, consolidation, and maintenance. However, the FDA approval only has approved it in induction consolidation. We don't know whether the benefit of midostaurin came only from the induction consolidation or also from the maintenance. So my recommendation often is to do it the way the phase 3 was done, because that's the only phase 3 data we have. However, there is going to be some challenges with whether it's approved by insurance in the maintenance setting or not. There is going to be subsequent study looking specifically at the maintenance impact, but this will take a few years. However, at this time, I would just go by best available data, which is using it in the way it was in the phase 3, where it was in induction, consolidation, and maintenance.